We are live.
Good evening, everyone. Welcome to the iFocus online lecture number 467 of the Refractive Surgery module number 18. Today's topic for discussion is the complications of Microkeratome LASIK. This will be taken up by Dr. Prateeksha Sharma, ma'am. Welcome, ma'am. The
Thank you,
moderator,
Sylvie.
the moderator for today's class, Dr. Namrata Kabra, ma'am. She has done her MBBS and MS Ophthal from the Government Medical College, Aurangabad. She has obtained her FICO in optics and basic sciences. She has done her cornea training from Shankar Netralaya, Chennai. Currently, she is the senior most consultant at CFS. Ma'am has done various phaco-refractive and corneal surgeries up till now. She is the pioneer of femto-assisted lamellar keratoplasty in the West India. She has had various publications in national and international journals to her credit. Ma'am is a passionate teacher and she has trained long-term cornea fellows and also is a guide to postgraduate DMV students. Ma'am has received various rewards, which includes prestigious Helen Keller Remembrance Day Award for the outstanding services at Shankara Netralaya in June 2019. She has received International Hero of Maharashtra Ophthalmologic Society Award in October 2023. She is also the winner of AIOS Hackathon Innovation Contest 2024. Welcome, ma'am.
Thank you, Dr. Survin, for your generous words.
Today's chairperson, Dr. Saeed Mas Mohudin, he has done his MS from Osmania Medical College. He is a DMB and FRCS from Royal College of Glasgow in UK. Sir has done his fellowship in cornea anterior segment from prestigious LV Prasad Eye Hospital. Currently, he is the consultant refractive surgeon at Center for Sight Eye Hospital, Hyderabad. Sir has performed various keratorefractive surgeries and has been practicing for the last 17 years. He is the first surgeon to perform no blade, no flap smile procedure in South India. Sir has various numerous publications in PubMed Index journals and multiple presentations at national and international conferences. He has received Best Poster Award in the ESCRS in 2017, Gold Medal at IIRSI, and CK Rashmi Endowment Award as well. Welcome, sir.
Thank you for your introduction.
The speaker for today's class is Dr. Prateeksha Sharma, ma'am. Ma'am has done her MBBS from Lady Hardinge Medical College, New Delhi, MS from Maulana Azad Medical College, Delhi. She has completed her senior residency at Guru Nanak Eye Center, New Delhi. Currently, she is the associate consultant at Center for Sight, Haryana. Previously, she has worked as a specialist ophthalmologist in ESI Hospital, Haryana. She is the recipient of Champions Award at YOSI. She has a distinction in medical training. Ma'am has authored over 30 journal articles and given over more than 40 presentations and lectures at various ophthalmic meetings nationally and internationally. We welcome you, ma'am. And
Thank you,
over to
Sylvie.
you, ma'am.
Yeah. So I'll be sharing my presentation. Is my presentation visible?
Yes, ma'am.
Okay. So we will start with the topic of microkeratome LASIK complications. So LASIK has been suggested by some surgeons to be the procedure of choice for virtually all myopias as well as low and moderate degrees of hyperopia. We all know this. And LASIK, but LASIK exposes the eye to the risk of creating corneal flap with a microkeratome. So what are the various risks which are included, which are associated with LASIK is buttonholes. Basically, we are talking about the flap related complications. So there could be buttonholes, there could be free caps, thin flaps, incomplete flap, irregular flap, or eccentric flap. And in extreme cases, we could also have perforation of the cornea or damage to lens and iris. There are also postoperative complications associated with flaps, including flap folds, displacement of flap, inflammation under flap, infection under flap, and epithelial ingrowths. So these complications can result in glare, decreased best corrected visual acuity, as well as loss of vision. So for these reasons, a poor keratectomy may be the worst worrisome type of LASIK complication. So LASIK popularity has surpassed that of the PRK, photorefractive keratectomy or surface ablation, with its benefits including more rapid recovery of vision, less post-op discomfort, and low risk of post-op stromal haze in high refractive corrections. So benefits lie in creation of a corneal flap and maintaining the surface epithelium and Bowman's layer prior to laser ablation of the stromal bed in LASIK. So although LASIK has several advantages over photorefractive keratectomy, its primary disadvantage is the flap-related complications. So as with other surgical refractive surgical procedures, LASIK may be associated with either intraoperative complications or postoperative complications. The literature says that the incidence of complications reported range from 0 to 20%. So these are the total amount of complication associated with LASIK. But the incidence of intraoperative complication in the literature is about 0.7 to 6.6. These complications occur infrequently with skilled surgeons, reporting to about 1 to 2% of the minor complications and 0.2 to 0.3% of the major sight-threatening complications. So how can we avoid this? So first of all, the main importance lies in the pre-op workup. So recognizing the pre-operative patient-related factors is very, very important. Then accordingly, we can modify the surgical techniques, surgical parameters, and patient selection. Although some complication can be avoided with careful planning and to details, others are unavoidable. Whenever complications occur, early recognition of the problem with prompt management in restoring an optimal outcome. So talking about the complications, first of all, we'll talk about the intraoperative complications. The first one is the poor exposure. So whenever there is a poor exposure or inadequate globe exposure, this could lead to improper placement of the suction ring, inadequate suction, or flap-related complications. And inadequate globe exposure can also lead to it prevents the smooth passage of microkeratome, leading to further complications. So how can we prevent this? So proper pre-operative evaluation of the orbital and facial anatomy is very, very important. Any history of facial or orbital fractures, sunken or small eyes, prominent brows, or narrow palpebral fissure. So lid speculum. So in such cases, in such high-risk cases where you see a sunken globe or a small eye or a prominent brows, what can we do? We can put the lid speculum with a slight posterior angulated hitch and a locking mechanism can improve the globe exposure. Then head positioning should be done properly. Proper draping should be done, as sometimes due to the small eye, the drapes come in the pathway of the microkeratome. When necessary, assistant may extend a downward pressure on the lid speculum to proptose the eye during microkeratome pass. So these are the small things or tricks which we can use. Occasionally, the microkeratome pass can be performed without a lid speculum with the tape used to isolate the lashes. And in rare cases, lateral canthotomy or retrobulbar injection may be given. So what are the problems that we face in such eyes? So first thing is that there is a poor placement of the suction ring, as a result of which the further complications follow. So there is incomplete pass of microkeratome due to interference from the drape, lids, or redundant conjunctiva. And lastly, a PRK should be considered in this challenging subset. PRK or any other surface ablations can be considered in such challenging subset of patients. So as we can see in this case, the cornea is bifid. The flap is bifid with peninsula of the uncut stroma as caused due to defective microkeratome blade pass. The second, first is your poor exposure. The second could be inadequate suction. So inadequate suction or loss of suction can lead to serious problems during microkeratome pass, such as thin flap, perforated flaps, or precaps. The proper placement of the suction ring requires adequate exposure and surgeon's attention to details. Now, how can we prevent this? Surgeon and technician must be very, very familiar with the working of the microkeratome and the suction mechanisms. They may be falsely reassured by the readings on the suction console when in fact adequate suction has not been obtained. So how can we cross-check whether the adequate suction is formed or not? So there are three things that we have to notice. It is advisable to look for the signs of pupillary dilation, transient loss of patient vision. You can ask the patient, and sufficient IOP. That's the third thing, that we can measure the IOP by Barrett's tonometers. So IOP should be at least 65 mm of Hg. So what are the problems that we face in such case? There could be redundant conjunctiva or chemotic conjunctiva as a result of repeated failed attempts to obtain the adequate suction. As a result, pseudo-suction is formed as conjunctiva obstructs the orifice of the suction ring. So what can we do in such cases? How can we reduce the chemosis? So we can expand the lid or chemosis of the redundant conjunctiva. We can expand the lid speculum, which leads to stretching of the conjunctiva. Rarely a conjunctival peritomy needs to be done to place the suction ring directly on the bare sclera for adequate suction. Now, conjunctival chemosis could be iatrogenic. Whenever there is difficulty in placing the suction ring, we try to place it again and try giving suction. This leads to chemosis. So patience is the best remedy. We can wait for 30 to 60 minutes. Minor chemosis may resolve on its own. Or what we can do, we can drain the fluid, as can milking the fluid away from the limbus using a blunt instrument such as Merocil sponge. Safest option remains delaying the surgery for several days. The next is thin flaps and buttonholes. The buttonhole flaps, especially the thin flaps, are among the most common LASIK flap-related intraoperative complication encountered, with the incidence starting from 0.1 to 0.2%. What can be the causes of these thin flaps or buttonhole flaps? First is surgeon experience. Second could be inadequate suction, corneal anatomy, or microkeratome malfunction or defect. With the loss of suction or inefficient elevated IOPs due to microkeratome pass, buckling of the central cornea may result in thin or perforated buttonhole flaps. So you can see in this picture, when the IOP is not well formed, as a result, you can see in the fourth one, there is buckling of the cornea. So this buckling leads to formation of buttonholes or perforated corneal flaps. How can we prevent this? Again, the most important is to check the adequate suction is formed or not by checking the IOP. So as you can see, when the IOP is low, the buckling of the cornea occurs. So how can we check the IOP? You can see the numericals coming in the suction, the console of the suction machine, as well as you can check the signs as we have discussed earlier by looking at the asking for the vision loss, looking at the dilation of the pupil, or you can even directly check the IOP using Barrett's tonometer or pneumotonometer. Then what are the high-risk patients where these cases can occur? So patient with excessive vitreous syneresis or a history of vitrectomy due to leads to difficulty in maintaining high IOPs using the suction ring. The next comes the abnormally steep cornea. So the corneas which are steeper than 47 diopters or which are irregular surface, if there is a history of PK or buckling, there is increased risk of buttonhole flaps or the flaps with central thinning due to corneal buckling during microkeratome pass. How can we prevent this? By using a thicker plate or a smaller ring. Avoid lamellar cut, and ultimately you can, if you don't want to take risk, then you can proceed for surface ablations. So what are the things that has to be kept in mind to avoid such complications? So first is microkeratome malfunction. You have to check your microkeratome very well before proceeding for surgery. Then second could be poor blade quality. And sometimes the repeated use of the same blade in different surgeries can also lead to such type of complications. Then meticulous attention to the cleaning, assembly, and pre-operative assessment of the blade and microkeratome system should be done. A lot of time, a lot of salt get deposited in these machines, in this assembly. That has to be cleaned very well, and assembly, it has to be assembled very well. Avoid manual torque of the cornea during microkeratome pass. So what are the treatment? What can we do when we see a buttonhole? So when a buttonhole flap created, you can either replace the flap and abort the surgery and wait until 3 months. And then you can recut a thicker flap after 3 months. Or if the there is a thin flap without buttonhole is created, if the central flap is of adequate thickness, ablation can be done. Or you can convert immediately to trans PRK or surface ablation after repositioning the defective flap. Then what are the risks in such cases once you convert it into PRK or you continue with the same? So there are high risk of haze with PRK. There is increased risk of epithelial ingrowth, irregular astigmatism, stromal scarring, and even flaps drying. The next comes the incomplete flap. So what are the causes of the incomplete flap? Whenever there is interference with the forward movement of the microkeratome. Now this interference could be caused by a speculum. It could be due to lids, it could be due to lashes, could be due to conjunctiva, or it can be drape itself. So even the small things matter a lot. Then other could be like electrical power outage, or there is loss of suction, or there is problem with the gear mechanism. There is premature release of the foot pedal, improper assembly of the microkeratome system, or again, as I mentioned earlier, salt crystal accumulation causing excessive friction in the forward movement could lead to incomplete flap. So how can we prevent this? So starting from the very basic, that there should be good exposure. The draping should be very well. The speculum should be put in with a posterior tilt so that most of the globe is exposed and there is little bit of proptosis. Then eyelids should not come in between. So these small things should be kept in mind. Then proper maintenance and cleaning and pre-operative assembly of the microkeratome suction ring should be done. Now, once the incomplete flap is formed, what could be done? So the treatment includes two things. First, look at the hinge. If the hinge is near but outside the outer border of the planned treatment, then laser ablation can be performed. If the hinge is more central, it is better to repose the flap and delay the surgery for 3 months. Now, what should be avoided? Avoid temptation to manually complete the lamellar cut, as this can lead to irregular astigmatism and scarring. And if risk is unpreventable, consider or go for surface ablations. Then comes the pre-caps. So the flaps with 360-degree cut and no hinge. So what are the causes for such things? So mechanical. First is mechanical. Again, the assembly of the microkeratome and suction ring needs to be proper to ensure sufficient advancement of the stopper. Then second is proper assembly of blade and microkeratome into the back. Then there could be anatomical cause. What are the anatomical cause? We have flat corneas. The cornea is less than 41 diopters, or the diameter is more than 14.5 mm. Insufficient amount of cornea is presented to the microkeratome through the suction ring, which may result in smaller diameters and free cap. You can even see in the picture. How can we prevent? Understanding the risk factors with corneal curvature less than 41 diameters and diameter more than 14.5. These are the high risk factors to be kept in mind. Then use a larger suction ring, or better to go for a surface ablation. Then what are the treatments that could be done for a free cap? So maintain the orientation of the cap. So whenever you see that there is a free cap, the orientation of the cap has to be kept in mind. So how could you keep the orientation of the cap? Either in the pre-operative, before forming the cap, you mark the cornea, or in case you have recognized that the free cap is formed, that time also you can mark the cornea. To keep the cap protected, place it in an anti-dissection chamber with epithelial side down while ablation is being performed. And once the free cap is formed, you have to secure the cap. You have to prevent the desiccation. Upon completion of ablation, the cap should be replaced on the stromal bed in the correct orientation, taking advantage of the corneal markings made prior to microkeratome cut or repeat marks made upon realization that a pre-cap has cut. Then interference irrigation can be done with careful attention as not to overly hydrate the cap. That has to be kept in mind. Now, to ensure the good adherence of the cap to the stromal bed, some recommend a prolonged drying of at least 5 minutes prior to removing the lid speculum and allowing blinking. So, you have to wait for at least 5 minutes till the there is drying and the cap is well adhered to the cornea. Then strier test can be done to ensure good adherence, as can make note of the symmetrical small gutter. So with a Merosis sponge, look at the gutter which is in between the cap and the rest of the cornea, that it should be symmetrical and it should be dried. Then rarely we need to suture the cap or use a glue. In some cases, BCL could be used, but the use of BCL is controversial. It may result in dislodgement of the pre-cap, or it may be helpful if the disruption of the epithelium has occurred during the procedure. So some people recommend BCL, but the size of the BCL has to be kept in mind because it might lead to dislodgement of the cap, of the pre-cap, but it is helpful in securing the epithelium. Then we have epithelial defects. So these epithelial defects, it could be preoperative or it could be intraoperative. So what are the risk factors for the epithelial defect? So history of dry eye. So preoperative assessment of dry eye is very, very important before proceeding for any refractive surgery. And then patients having basement membrane disorders. Again, a preoperative clear slit lamp examination is very important to rule out any of such disorders. And if there is any history of recurrent erosions, that should be asked. Then test the epithelial adherence. A pre-op slit lamp examination using a dry cotton tip applied to the surface of epithelium after installation of topical anesthesia is could be done to look at the strength of the epithelium basement membrane. Then in such cases, if you have any doubt, then we can go for PRK or surface ablation. Now, in order to avoid what things to be kept in mind, to avoid such epidefects to be happening intraoperatively or postoperatively, avoid excessive topical anesthetic eye drops. So much of eye drops putting in preoperative phase is can lead to epidefects or loosening of the epithelium. So that should be avoided, especially ones containing the preservatives. Then use of the proper assembly of microkeratome. That microkeratome pass should be smooth and it should be in one go. And while assembling also, everything should be kept in mind and there should be a proper assembly of the microkeratome. Then lubricate the surface of cornea and microkeratome tract. That is again very, very important. The dry surface could lead to multiple epidefects or could even erode the total epithelium. So lubricating the surface of the cornea, the microkeratome tract again and again is very important. Keeping the patient calm to avoid excessive eye movements. In some cases, when the patients move their eye and the eye moves under the speculum, it can lead to epidefect. And also while we are engaging the cornea with the microkeratome and patient is moving the eye, it can again lead to epidefects. So keeping the patient calm by explaining the every step that we are going to perform and by decreasing the anxiety of the patient, we can avoid this. So keeping the patient calm to avoid excessive eye movement, avoid use of tooth forceps in reflecting the flap. So the flap should never be handled with a tooth forceps. That is to be kept in mind, and best to use is a Merosil sponge. Tooth forceps is a big no. Then avoid aggressive marking of the flaps. Even while marking the flap in the pre-op or even after formation of the flap, they should aggressive marking should be avoided. Avoid improper use of dry sponges on the corneal surface. So again, since already the epithelium is used because loose because of excessive, sometimes because of the anesthetic drugs or the antibiotic drugs or too much of lubrication. So Again and again, drying the surface or using dry sponges on the corneal surface can lead to epi defects, so that should be avoided. Then in case if you see the epithelium is disrupted during the surgery, so this is intraoperatively if the epithelium is disrupted, then the attempt to smooth the epithelium back to its original position using cellulose sponge is very, very important. So to be kept in mind, only use the cellulose sponge. We should not use any other instrument to keep the epithelium back. With the help of Merosil or a cellular sponge, try to keep this epithelium back to its original position. But if you cannot reposition this epithelium, then the epithelium tags should be removed. So these tags should be removed very carefully, not to disturb the rest of the healthy epithelium. Avoid introducing epithelial remnants under the flap. And once you see that the tags are coming out of epithelium, and while lifting the flap, make sure that these tags should not be introduced under the flap. So that is to be kept in mind. It is very important. Loose fitting bandage contact lens can be used until the surface is fully epithelialized in case of severe epithelial disruption. Again, use of BCL is very controversial, but in cases where epithelial defect is big, so in such cases, BCL lens should be used until the epithelium is fully grown back. Then we have decentered flap. Now, what are the causes of the decentered flap? It could be due to decentered suction ring. So, starting from the first point itself, if you have not put the suction ring properly, so how do we see whether, how do we check whether the suction ring is put properly or not? You have to look at the limbus, that the view of the limbus should be same in all the directions. So decentered suction ring is the first cause. Then globe torque, while putting the suction ring or while manipulating it, we can lead to torque of the globe, that should be avoided. Then loss of suction in between. So again, the suction loss, we have to check again and again. It has to be put properly and the suction should be proper. That means the IOP should be more than 65 mmHg, that we have to keep checking by looking at the pupil, by asking a patient for the vision loss, or we can check the IOP also. Then lack of patient cooperation can also lead to decentered flap. Then in error in centering the optical axis is again a cause of the decentered flap. Now, what is the treatment? Once you have decentered flap, then what is the treatment? Look at the flap. If there is a slight decentration, then you can continue with the laser ablation. If there is a large decentration, then flap has to be repositioned and postpone the surgery for 3 to 4 months. So in such cases, when there is a large decentration, what can happen? If the ablation is done eccentric, or if it is done just below the hinge or below the flap, what happens? It can lead to it induces astigmatism in such patient and even lead to destruction of the flap. So whenever there is large decentration or the hinge is coming in the ablation area, it is near the center, then in such cases, the flap should be repositioned and surgery should be postponed for 3 to 4 months. Then corneal perforations. So these are the very rare, these complications are very rare with the newer generation of microkeratome. The causes of the corneal perforation could be improper microkeratome assembly. It could be due to failure of the properly placed depth plate into microkeratome assembly. It could lead to aqueous leak and to early recognized, uh, as early as you recognize this, stop the power and suction and protect the eye with a shield immediately. Thank you. So,
Thank you, Dr. Prateeksha. Thank you so much for sharing all those tips and tricks with us.
ma'am and sir, you want to add anything? This was from my side.
I would like to request Dr. Math sir, with his huge experience in keratorefractive surgery. So what is your protocol for microkeratome LASIK? Do you mark patient before starting or before going ahead with flap making? And if yes, then how many number of marks with markup pen or with the help of blunt instrument? Would like to know.
Correct. I've been doing refractive surgery since 2005, and initially, till 2009, we didn't have a femto laser. So in those first 4 years, 70 to 80% of our patients used to be microkeratome LASIK surgeries. Now, as femto lasers have come, the percentage of microkeratome LASIKs have started decreasing, but still we do about 20 to 25% of keratorefractive surgeries are still microkeratome. But now I know that there are some surgeons who are coming who are absolutely not touching the microkeratome. But I think that is not a right way of approaching, because microkeratome LASIK still does have its own, advantages. I would say, with the faster recovery and uh, ease of surgery if you are well trained in it.
But
Regarding
it's
your
always
question
a
of
good idea to know how to use all the weapons in your armamentarium.
correct. Absolutely, absolutely. So still, we are a developing country, and price is still an important,
I
thing which
think
patients consider. So investing in a femto laser and the costs involved, and microkeratome LASIK, we had a presentation just now, a very good presentation on complications. But let me tell you, if you're very well trained, you hardly get to see any complication with a microkeratome laser, provided you do a good check. So right from your pre-op evaluation, just see to it that your orbital rims are not too prominent. Okay, too prominent orbital rims, you might have a problem placing the suction. That's number one. The second thing is, during the surgery, as you have very rightly said, check for getting the right amount of suction. The important thing is that you train your ear for that, and you should know how to pick up the sound of a pseudo suction. So pseudo suction is a typical hissing sound. So that sound, if you know how to pick up in your microkeratome, it's very important. So here you are not just using your eyes and your hands, you're also using your ears, because the pseudo suction sound should be picked up. And then, as Dr. Namrata has rightly said, pre-operative marking is very important. I put 3 marks. So 2 marks are at the 6 o'clock position, and 1 mark would be where, at the temporal edge. So even if I get a flipping of the flap, then I would know that which side is correct. The other thing is, have a sterile fluorescein strip always inside your OR. Okay, so even if the marks wear off, just put a little fluorescein on your conjunctival cul-de-sac, and if you are on the right side, only the edges would stain. If you have flipped it, then your entire cornea would stain. So just having a small an extra sterile fluorescein strip is very important. Another thing which you should be having is a vial of epitrate. So sometimes with microkeratome flaps, because the flap size is more than what you get with a typical femto laser, you might have some bleeds at the limbus. So just a little drop of phenylephrine there would solve the problem. And decentration is quite rare if you mark the pupil center correctly, and you just get the right amount of suction. One thing which happens more with your microkeratome flaps is DLK compared to your femto lasers. So you should be always seeing your patient's first post-operative day. And if DLK does occur, and if it's a grade 3 or 4, do not, waste time. Just go and take the patient in the OR and just wash the interface. Washing the interface clearly helps with removal of toxins, and gets you very good results. So pre-op and surgery and post-op, these are one or two points which I wanted to add. Otherwise, a very good presentation, and I hope many more people take up microkeratomes in their practice, because definitely at a lesser cost, you would give the wow factor of 20/20 vision on the immediate post-op day, which might not be there with PRK, surface ablations, and sometimes even with your lenticule-based surgeries, you might take about 2 or 3 days to get that wow thing, which you would get just in 24 hours with the microkeratome. Thank you.
Thank you. Thank you so much, sir, for sharing all those precious tips and tricks. And as you rightly said, DLK is also one of the post-operative complication. And for DLK, couple of practical things I would like to share. Previously, I remember we used to ask patient not to apply eye makeup or discontinue eye makeup 2 days prior to surgery, and then we realized with passage of time, longer lasting eye makeups, eyeliners, kajal, pencils, these are available. So nowadays, what we have started is we ask patient to discontinue eye makeup as early as 1 week before surgery. So there are no residues. Then recently I had one case where patient was applying surma. That is also one of the practice in some of the communities. So you have to specifically ask patients to discontinue all these things, because all these particulate matter, if it stays back in interface, can give rise to DLK. Apart from that, something which is so very important and has emerged as one of the most important factor these days is MGD. If you see lids are having any evidence of mebomitis, please treat it beforehand and go ahead with surgery in healthy environment. Like, the milieu should be healthy, because it's now very well known MGD can also give rise to DLK. Otherwise, if you take care of all these things, chances of DLK or prevalence of DLK as such per se in microkeratome would be less than femto-LASIK, because in femto-LASIK, whatever additional energy which is being used for flap creation, it's known to cause DLK. Of course, these days, even femto lasers, they have decreased their energies, especially like third, fourth generation machines. So chances of DLK have drastically gone down. So, and yes, I would like to add on in Prateeksha's presentation part, as in many of the situations you have shared rightly, when it's, inadequate exposure or very small IPF, PRK is one of the option, or at times even femto-LASIK is one of the option, because the amount of exposure you require in case of femto-LASIK is less as compared to LASIK. Of course, if nothing is feasible, then PRK is also one of the option. And also hinge location. Some of the machines in MK LASIK, they have particular hinge location. If you want any customization for any specific purpose, then femto-LASIK can again be considered. And your presentation also reminded me of JCRS journal, November 2005. The title page, the cover picture showed a heavily injured, dreaded eye picture with iris incarceration, cornea being cut, and that was post-LASIK complication. Though this is, at one hand, something which happens very rarely, I would like to reiterate, LASIK is not a demon or devil. If we know how to operate and how, all those nuances are so very important to make good use of this wonderful tool, in fact, I would say.
Very well said.
Also, sir, I want to ask, what is your experience with free caps? Like, how do you proceed when a free cap occurs?
Yeah. So once we had a microkeratome which used to give more free flaps than normal. So I mean, Personally, I have encountered more than 20 or 25 free flaps in my this thing. Absolutely no problem whatsoever, provided you have done a good marking. It's not just important that you keep the side right, it's also important, the orientation right. It's also very important that you keep the rotation right. Now, the rotation is important because when you're making your flap is thicker in the periphery and thinner in the center. Okay. So the same thing is there on the bed. Okay. So your flap is thicker in the periphery and thinner in the center. It's actually like a concave lens. Okay. And similarly, the bed is more like a convex lens. So both of them should minimize each other to give a zero astigmatism. Now, it is said that it is about 2.5 diopters. So if you misalign the vectors, you might get irregular astigmatisms. Now, if you ever get an irregular astigmatism with misaligning of the flaps, okay, then there is a formula based on the positive visual axis, based on the plus axis. So if your plus axis is less than 90, you rotate it clockwise, and if it is more than 90, you rotate it anti-clockwise. So on the top of my head, I don't remember the formula, but it's in a book by uh, uh, there is a formula as to how to rotate the flap if there is a misalignment. I had done it only once and it gives excellent results if the rotation has been misaligned. But free flap, I think, should not be too much of a dreaded complication, provided you keep your cool, you do your laser, you save your flap, and you put it on the right side. And the second thing is the buttonhole. For a buttonhole, I would suggest that you do not do the surgery on the same sitting and you postpone your surgery. And the best and the safest option would be that you don't do a PRK in such cases, because if you do a PRK, the chances of epithelial ingrowth is much more higher. So you just save the cornea, give the cornea rest, and the most safest way would be you do an ICL on those patients so that the cornea is saved and you do a lens-based procedure. So I think a more dreaded complication would be a buttonhole rather than a free flap. And keep your antennas raised in free flap. Anything below 42, see to it that you use a bigger sized suction ring, typically about 9.5 if your K reading is less than 42. Okay, so if it is less than 42, better that you are prepared that you might get a free flap, which is rare. But yes, below 42, it is more common, and more than 42, it rarely happens. I want Dr. Cabra to add in if she wants to with her experience with this.
I would, at this point of time, I would also like to add on that staff also needs to be trained whenever, or as a habit, whenever you hand over microkeratome head to your staff along with ring, no manipulation should be done till you raise the flap. At times, the free cap is engaged in the very instrument itself. And if your assistant is not well trained, there are chances that you may miss out your free cap completely. So every time your assistant receives the assembly, it should be treated as if there is tissue within this assembly by your assistant. That is one thing. And as sir has very rightly mentioned, and thank you so much, sir, for sharing that formula of misalignment and adding that precious input in this discussion. In case of free cap, one more thing I would like to add on. Recently, one of my colleague was operating and she had a free cap in one eye and thought of getting free cap out of patient non-cooperation and didn't customize ring size. So that's probably an alarm. Okay, you need to check your ring size once again. And as Sir rightly mentioned, you can go for larger ring size. You need more tissue to be engaged when it comes to flatter cornea and risk of free cap. In case of buttonhole, reverse is the case. If it's steep cornea, try to engage little less tissue so that chances of buckling of tissue and buttonhole would be little less. Of course, given a choice, I would say flatter corneas less than 42 or 41 and steeper corneas more than 47. If you have access to femtolesic would be a better choice.
Agreed.
At one point of time, I used to have access for only microkeratome and I used to perform only microkeratome LASIK. But since more than a decade, have access for femtolesic as well, then probably the extreme keratometry value patients, they are being selected or being, posted for femtolesic rather than LASIK. So chances of pre-cap or steep, buttonhole, you can minimize that way as well.
Ma'am, do you prefer using any glue or suturing the free caps, or you just use BCL over the cap and secure it?
Seal is sufficient, and for marking, I use blunt instrument because some of the cases have been reported with the ink marker, ink marker, DLK. Has been reported. So, and secondly, the ink mark can get smudged. So I feel marking with blunt instrument like hockey stick knife or any blunt instrument gives you more accurate, sharp marking. And as Sir said, I too keep it asymmetric so that, one can align with the orientation. And you have very rightly pinpointed, the gutter should be uniform. All these things, it does help for proper orientation and replacement.
How much epithelial ingrowth have you experienced after free caps? Like there is lot of manipulation done at times.
My personal experience with free cap is very limited because, as I shared, I had access to femtolesic, so all the extreme cases were posted for extreme, keratometry, odd keratometries were posted for femtolesic. But yes, being in tertiary eye care center, we used to get referrals with epithelial ingrowth. Many of cases we have treated with YAG laser, and it does work well when it comes to mild epithelial ingrowth. So I'm very happy with the YAG laser of epithelial ingrowth. It again depends, I would say, how well you are closing and when you are doing revision, especially revision surgeries. Are you scraping off epithelium so that you are reducing chances of epithelial ingrowth? Your manipulation, your wash, and the time for drying up, as you shared, 5 minutes drying up. So your edges are snugly fit. If it's overhydration, I would say, then it would be kind of floating flap, and then there is a way or a way which is open, or a canal which is open space for epithelium to grow in. So all these factors and nuances keeping in mind does make difference, I think. Sir can add on.
Yeah, when you have a free flap, see to it that the correct orientation is kept on the cornea. So if you kept it epithelial down, some of the epithelial cells might stick to the underlying stroma. The other important thing is have the free flap only in the microkeratome assembly. Don't let it touch on any part of the conjunctiva. So if your stroma of the flap touches the conjunctiva, there might be transfer of conjunctival cells. Okay, that also results in ingrowth. And indications for treatment of ingrowth are also important. if there is irregular astigmatism, if it is more than 2 millimeters from the edge, or if there is some sloughing of the surface, then you need to go in and raise your flap. And when you're raising the flap, see to it that you go in a direction opposite where the ingrowth is, so that you don't push the ingrowth further inside. And once you raise the flap, see to it that you are just not removing the ingrowth from the stromal bed, but also from the undersurface of the flap. So how you do that is you use two different Merocell sponges, and see to it that those Merocell sponges are not, it's kind of like using a no-touch technique of how you would do for an OSSN. Okay. And once you have done that, I use a bit of mitomycin of the same concentration which we use for our PRK, 0.02%, and then give a nice thorough wash. And you put it back. And as Dr. Cabra has correctly pointed out, if there is recurrence, that means that the flap has not apposed well. This mostly happens in cases of hyperopic LASIKs or in retreatments. So in those areas, you identify the area, and there, if you give 1 or 2 tight sutures and you keep those sutures, say, for about 3 or 4 weeks, then these recurrences do not happen. Okay.
And there are some of the cases, they'll have epithelial ingrowth, but connect from edge would be lost.
Correct.
The edge is very well opposed. Then these are non-progressive epithelial ingrowths. So you have to decide or keep monitoring and seeing the minute nature of epithelial ingrowth, progressive versus non-progressive. This can be one of the factors to decide on treatment.
Yeah, to add another point here, another differential in a recurrent epithelial ingrowth would be an early endothelial dystrophy. So with early endothelial dystrophy, sometimes you have fluid retention on the interface, and because the flap and the bed are not sticking together, you have endothelium seeping in. So keep that also as a differential, early endothelial dystrophy. Do a specular in such cases. So we had a nice discussion. Anything else want to add? Or
Very good points you have added. Dystrophies and at times pressure-induced right keratopathy can also result in the same.
So, sir, do you practice like doing specular in every case in pre-op?
no, no. See, if you have a good, in which cases, if you turn around the question and ask me if which cases would I do a specular, I would do a specular if the central thickness is more than 600 microns. If the difference between the central thickness and the 5 millimeter peripheral thickness is less than 100 microns. Okay, in these two conditions, I'll do a specular, and I would do a slit examination of all my cornea cases. So if I get these two pachymetry things, then definitely I would get a specular test done. And if you have an access to a pentacam, and if the pentacam shows in the PTI, progressive thickness index, in the periphery, if it shows a S-shaped kind of a pattern, then I would get a specular done. So three reasons, but not in all cases.
So what's your thickness, flap thickness preference usually? And
Yeah.
also this
I use
Prateeksha
yeah,
protocol.
110, 110 with a zero blade. So you have those blades with +10, -10. So we use a zero blade and a 110 micron head.
And Dr. Prateeksha, what's your protocol or preference for flap thickness in
And
micro?
I also go for same like 110 at 0. Mhm. Mhm. Surveen, any questions? You are on mute. Mhm.
There's one question, ma'am. Can we do any customizations to the microkeratome while we make the flaps?
Dr. Kabra can take the question.
Suvin, I would like you to elaborate your question. I couldn't get your point.
Can we make a, if we want, what is the extent of the thickness to the maximum and the minimum which we can make with the microkeratome flap?
If
The maximum flap and the minimum thickness of the flap.
Okay, see, minimum is 90 micron, which is available with many of the machines, and maximum thickness is different again with different machine. There are almost 12 different microkeratomes and head available from 12 different companies with so many variations, but thicker is no more preferred. Like 130, when LASIK was launched, people used to go for very thick flaps, because probably those days the only concept was RSB, residual stromal bed thickness, should be more than 270 or minimum 270. This concept no more holds true. I think with person tissue ablation and tissue saving surgeries, thinner flaps, keeping more residue in view of risk of future ectasias, thinner flaps are always advisable and preferable. Of course, with the advent of SMILE, there is one counter view, like deeper lenticule extraction with thicker cap thickness. It does help to preserve corneal strength, because superficial or anterior corneal stroma, it has more biomechanical strength, I would say. So still biomechanical strength concept is evolving, I would say. But as of now, this is something which we follow. And for flap thickness, when we choose or select a particular microkeratome, apart from that, there are other variables or other factors which can create variable flap thicknesses, like is it fresh blade? Is it, blade which has been used before? Like fresh blade would be sharper one and will give you little deeper flap than, intended at times. Like it has standard deviation, microkeratome flap has. If it's blunt blade, then it might give rise to, little thinner flap. So all these factors should also be taken into consideration. And
I
then
would add one thing to this. Microkeratome, use one more which we can touch and discuss later, is use of microkeratome to make DSEC tissues. Okay, so in your question, the thinnest is, as ma'am has said, 90 microns. The thicker ones are not used for normal eyes, but they are used when you are making DSEC tissue preparations. Okay, so you get that at 400 micron thickness. So what you do is, in an artificial anterior chamber, you dog the donor eye, and then you make a cut with a superficial thickness of 400 microns, and you have a nice 100 micron thin dissect tissue. So you don't need to do those dissections on the table. You just need to do a punch. And in Hyderabad, we get these supplied from our main eye bank at LVPI, where they have, they supply these are called pre-cut tissues. So that pre-cutting is done again by a microkeratome, and in that the head used is about 400 microns. So this is not used on normal eyes, only on donor eyes.
This is like ALTK system, which has different application.
Correct.
Or else, if you don't have thicker like flap making blade, then you can go for double pass. That is also one of the technique for preparing such tissues.
Correct.
Or by chance, if you have very, very thick cornea or swollen up because of n number of reasons, then also you can go for double pass based on ultrasound check of pachymetry, of course.
Thank you, ma'am. Thank you, sir.
Thank you. Thank you. Very nice presentation. Very good discussion.
Thank you, Dr. Prateeksha, for all those efforts.
Thank you, ma'am. Thank you, sir. Thank you, Sylvie.
For adding So many precious inputs. And thank you, Survin, for your utmost sincerity and commitment. Every week you are there with such an interesting masterclass on refractive surgery. Thank you. Thank you, everyone.
You
So much.
all. Bye bye. Good night.
Bye.
Goodbye.